Next speaker is actually Janet Gale. Janet Gale is actually going to be talking about, well, what happens when the patient doesn't dance with you. Janet Gale is a health psychologist. She's the managing director of Health Change Australia. She's a member of the Australian Psychological Society College of Health Psychologists, Deakin University Clinical Exercise Physiology Advisory Board, and is also a member of the New South Wales Health Department Chronic Disease Management Program Clinical Expert Reference Group. I'd like to ask Janet to come up and talk about her experiences and her advice on how we can actually have two people dancing the tango. Thank you.
Good morning, folks. Health Change Australia, Health Coaching Australia, we have a team, a very multidisciplinary team of quite passionate clinicians who work with us to provide workshops around Australia in precisely what Peter so eloquently gave us a background to. How do you incorporate into your clinical practice all of those psychosocial issues as part of the biopsychosocial model? And it's not so easy when you've been trained in a particular framework to conduct your clinical practice. And we've got dietitians, OTs, nurses, 2 physiotherapists, a couple of health psychologists, and I hope I haven't forgotten anyone, but we all struggle with exactly the same thing. It doesn't matter what type of clinical practice you have, how do you actually mesh in these other issues that you need to deal with to try and help the patient, for their own personally motivating reasons, to do the things that you're advising them as a specialist to do. So that's what I'm going to talk about. All of those basic skills and techniques and principles that Peter was mentioning can be wrapped into a practice model that helps you negotiate and blend those two things, clinical practice and actually having the patient go out and do what you want them to do. So let's just have a look at some of the dynamics here. We know, and we spend a lot of money and resources in the health system and nationally in our practices, actually trying to adhere to evidence-based recommendations, finding those recommendations and getting patients to take action, because statistically we know that's the best thing to do. So if we do that, we're going to get better patient outcomes, and I'll let you guess what's in the middle there, and it's actually the human being. So what's going on? In order to achieve the better outcomes, you need to actually adhere to the recommendations or the targets or the treatment plan. That means that the patient needs to change their behaviour. So when we're talking about behaviour change, it doesn't mean lifestyle change. It's getting someone to do their rehab exercises, getting someone to bandage a wound. It doesn't matter what it is, attend a referral program. That means they've got to change the way they're thinking quite often, because that's when some of those psychosocial barriers come in. Just think about yourself, 6 o'clock in the morning, if you've ever tried to get up and exercise early before work, or maybe earlier than 6 o'clock. Have you ever talked yourself out of taking action? It's not psychopathology, it's just that you probably said, oh, it's wet out there, it's cold out there, I don't know that I want to bother doing that today. But if you're thinking in another way and say, oh, don't think, just get out there and do it, or whatever might work for you, then you're much more likely to take action. So it's not only those, clinical psychological issues that get in the way, it's everyday human being thinking, behaving, our emotional reactions. They're not in the pathological spectrum. So a patient has to be ready, willing and able to actually follow your advice. So far, the clinician's not in here. We're just telling people what the recommendations are. And the place that we can make a difference, if we do it in the right way, is in our clinical consultations. And that means you can't just stick to the clinical stuff. You've got to weave in the behaviour change. And anyone who's been out of university for any time at all, I know that a lot of you will intuitively know this. I know that you understand the biopsychosocial model. We've all read the literature on stages of change, health belief models, all of those sorts of things. But they don't tell you what to do with the patient sitting in front of you. So we can recognise these sorts of patients, and I must say that I've drawn from some of Caroline Bills, our senior facilitator and manipulative physiotherapist down in Melbourne who works with us. So she's come up with some of these slides that are physiotherapy centric, and this is one of hers. So, we all see patients like this. They'll say, yes, just tell me what to do. Does that mean they're ready to actually go out and do it? And often the people who sit there and say, yep, just tell me what to do, no worries. Can we finish this by past because my parking meter is going to expire? Or they might just say, yeah, no, I really will this time, I'll go and do it. These guys aren't as hard to sort of identify, you know. It's pretty obvious when someone's sitting there, you know, snarling at you or just completely switched off, particularly in compensation contexts, insurance contexts. So if you want to create that kind of resistance, here are some tips for you, because these are really good ways to make patients avoid doing what you're telling them to do. And we know from the motivational interviewing literature, a lot of these things actually hold. And things like scare tactics, that's interesting too, because sometimes scare tactics seem to work, but it's mainly when the person makes a connection themselves. And if they have low confidence, don't use scare tactics, because what that will do is create an avoidance response. By the way, if anyone is interested in these slides later, I'm happy to make them available to people. So what happens, we commonly see, it's a very technical term that we use at HCA, it's messy head syndrome. And what that means is, some of you might relate to this, it looks a bit like my desk. What it means is that the person is in a certain amount of emotional or cognitive turmoil, and it could be because they've got so many other priorities in their life that they don't feel like they can prioritise themselves. It might be that there's conflicting advice between the different practitioners they're seeing. Many people will be seeing, you know, a multitude of different types of practitioners. Which advice do they actually follow? Or it could just be that life is just too complicated and I don't know how to take action. Unfortunately, the thing that occurs as a result is this. It ends up in cognitive, emotional, and behavioural avoidance. So we don't want to really do that. But interestingly, even when people seem motivated, and chronic pain is a classic, of course. So if people say, I really want to get rid of the pain, and they're very motivated, it would seem, to get rid of the pain. But when someone says that, just keep in mind, are they actually motivated to take the actions that they need to take in order to get rid of the pain? So people focus on weight loss, pain management, fatigue management, those sorts of long-term things. They want the outcomes, but that does not mean they're ready to take the actions. People want a magic pill. So what's required for success? Of course, with the passive treatment cycle, you know, people with physiotherapy in particular, people of course come to you thinking that you're going to do something to them, and it encourages passive patient behaviour. So how do you actually get them to engage in that other active behaviour, active treatment cycle? So that's where you need to really understand, well, why aren't they changing? So there is a framework that you can use that can help you to identify what's going on. Why aren't they adhering to recommendations, or why might they not? Can I identify that up front so that we don't spend a lot of time me giving them the recommendations, we play the patient practitioner game, them going away, not doing it, coming back again when their symptoms flare up, and then me telling them again and they go away and they don't engage in the active treatment. So people need information. They need to understand what's going on, of course. Then that can lead to motivation, but it depends on the way also, following on from Peter, that we actually need to communicate the information in a way that they find useful and motivating, because it's really easy to demotivate. Then the person needs to make a decision or a commitment, and in our particular model, we've built in the decision line. That's the point in time where the patient says, you know what, I am going to take action. I see value in this for myself, not just because I'm being told to do it or told to go back to work or told this is necessary. After that, you can engage in the planning. The person can go out and take action. And then, of course, they've got to engage in self-regulation. So at each step along the way, there are things that can get in the way. There are barriers that can occur, particularly within the person's head. What can you do about it in a clinical consultation? Well, that's sort of what we've been working on over the last 8 or 9 years. So the first thing is providing information in a way that doesn't create that resistance is obviously going to help. And certainly for GPs and specialists and people who only have really short periods of time with patients, that's our biggest recommendation, is know what creates resistance and avoid doing that. And at least the patient's then got a chance with other practitioners. We've all got a 3-year-old still inside us. Think back to the first word, or the most common word that you hear is from a 2 or 3-year-old, it's the word no. Why does a 2 or 3-year-old say that? Because they're trying to assert their independence or their autonomy. And we've got that person still inside us, so it doesn't matter how well-intentioned we practitioners are. If a patient picks up that they're being told that they have to do something because that's what they have to do to manage their condition, then you get this instant no response, even though it's something that they might do if they felt they had choice about it. Informally assessing motivation and confidence can be quite critical, because if a person is not motivated, they are not going to follow your advice. On the other hand, if they're not confident or they feel overwhelmed, then they're also not going to follow your advice. By just checking in on that, you give yourself an opportunity to do something about it in a very brief intervention, and I'm talking about a couple of questions. Then asking questions to build motivation. Those of you who are familiar with decisional balance processes, that's one of the ways to do it. And asking questions that build confidence, particularly at the end of a consultation where someone might have quite a few things to go away and do, but do they actually feel confident in doing it? Or have they got a list of things in their head that they're likely to go away and forget as life gets in the way when they walk outside of a consultation? And just getting people to write down the things they're going to do before they go out is a really simple way that can help that memory process. So there's a complementary pathway. You've got your normal clinical pathways, but you've also got a behaviour change pathway. So you've got some informal assessment, and we're not talking about bombarding people with 0 to 10 scaling questions here. Then you've got a decision-making algorithm that practitioners can use, and in particular we call it the RIC principle. And Caroline, our physio, talks about having her RIC radar on when she's in physio consults. Is the patient ready? Do they think it's important to take action? Do they have the confidence in taking the action that's been recommended? And do they know what to do and why they're doing it in a way that's going to benefit them? It sounds simple, but if we just check in on those things, at least in our own mind, and then check with the patient if necessary, that can certainly help. So I'm just going to talk you through a couple of our key principles. They've already been touched on this morning, and they're going to be very familiar to you. But just then bringing it back into a physiotherapy context. So being client-centred, offering people choice and offering them control. That's tapping into that principle of autonomy. People have an innate need to act in accordance with their own values, needs and preferences. And whenever they feel that that's being threatened by well-intentioned practitioners who say, but you've got to do this, then you get a resistance building up in front of you, and you can see it quite often. But how do you balance that with duty of care? And giving patients choice doesn't mean that you're giving them the choice of clinical recommendations. You're not changing the clinical recommendations. You're making sure they know exactly what those clinical recommendations and targets, what the treatment plan is. But they're going to go away and do it or not. And that's something that we can't really change except for having a word with that person in the consultation before they leave, and maybe set them up to make the decision that yes, I'll do it rather than no, I won't. So here's one way that Caroline talks about it in her clinic. In particular, because of the issue of people coming up with these weird and wonderful ways of treating themselves, you know, bed rest for back pain, those sorts of things. How do you raise those issues without insulting the client, making them feel bad about what they might think is the truth? So she talks about what works, what might work, and what doesn't work. So regardless of what the patient's doing, then she'll talk about, so what are you doing now? When she's given that explanation in a very simple way, she makes it very clear what her own assessment, diagnosis and treatment recommendations are, then finds out what the patient's already doing, and that opens a dialogue about what they might do to help them to actually manage their condition. In the same way, a lot of physios find it difficult to raise the subject of active treatment, particularly when they know that their patient is coming in with a definite expectation of getting passive treatment from a physiotherapist. That's quite common. So this is the way that Caroline does it, and she talks about there's passive treatment, that's probably what you're expecting today, but for a condition like yours, we know that if you also engage in what we call active treatment, that's going to give you a much better outcome. So right from the very first consultation, you're setting up that expectation that the patient needs to be active in their own treatment. So later on down the track, when you start talking about lifestyle changes or environment modification, they're not surprised by that, and they don't feel like now you're giving them something else to do because you're setting up the expectations from the beginning. So the RIC principle is really our key principle, if you like. So that's Caroline calls it the RIC radar, and what you do is use it as a decisional prompt for yourself as a clinician. Does the person think that they're ready, think it's important, are they confident, do they have the knowledge that they require? And if you can't pick that up from the patient, because sometimes it's blindingly obvious, then you just simply ask the person. And again, not in 0 to 10 scaling questions, but you can use very simple language. I'll give you an example in a second. So there are 2 RIC rules, we call them. If someone's importance is low, they're probably not going to go out and do what you've suggested. So you need to be able to have some techniques up your sleeves to take action. And decisional balance, that is looking at the pros and cons of change versus not change, and using some techniques to tap into intrinsic motivators. What are you going to get out of it? So whenever you're in a consultation with a patient and you feel like they're not engaged, a really important question that you can ask yourself is, what do they think is in it for them? Because if they don't think there's anything in it for them, that they're really not going to gain anything from taking the actions outside of the consultation that you're suggesting, then they're simply not going to do it. And if confidence is low, we have another little principle called one thing at a time, one step at a time, but adding up over time. So again, you're laying out all the different things that over time a patient can do, but on the understanding that if you were to do them all at once, that might be overwhelming given their current life circumstances and their other medical treatment. So it's okay to start in detail on one thing, but add to that over time. So here are some ways of asking RIC. So asking about readiness doesn't even have to have the word readiness in there, quite frankly. You know, is this something you're prepared to do? Are you happy to work on a plan with me today? How much of a priority is another way of asking about importance. Because people will always tell you that health is important, but does that mean they're going to take action? Probably not. When you ask someone how important is it for you to take action, they'll normally give you an intellectualised response. How important is it for you to manage your pain? Really important. Okay, how much of a priority is it for you to go out and do your exercises 3 times a day and do the other activities that we've said, given everything else going on in your life? And that's where the importance starts going, maybe not as much. So can we just talk about that for a moment? And confidence, you really want to know that the person feels they can and will go out and do the things you've suggested. And that's where you start to unpack the barriers. We talk about barriers as being behavioural, emotional, situation and thinking barriers, and that's that BEST acronym I had up before. So the first thing that most clinicians across all professions will say is, I don't have time to do this kind of thing. So one of the ways that you can grab back some time, and actually it's only probably an extra 5 or so minutes you're talking about in terms of asking the right questions and talking things through, but consider whether or not you are over-assessing patients, either in your teams, your programs, your organisations, or just in your own clinic. Think about whether or not you're giving too much global education and everyone gets the same thing for the same condition, because that's a place that you can actually drag back time. If someone's got barriers there, if they're not ready, they don't think it's important, they're not confident, they don't have the knowledge, that's going to be a barrier whether you ask about and identify those barriers or not. So if you're able to at least raise those as topics of conversation, patients will go out and think about them. So I'd like to finish off by just giving you a little bit of patient feedback. So this is one of Caroline's patients, and I asked her to simply ask her patients what they thought of the approach that she's been taking. Because over the last 18 months, she's really worked on integrating this practice model into her physiotherapy practice, and she has had some interesting changes. And she's a person who's quite knowledgeable in the psychosocial aspects, as I said before, but didn't know quite how to weave it into her clinical consults in a time-efficient way, because that's so important. So this lady obviously has MS, and in the little audio here, she talks about a holistic approach. So I've listed what a holistic approach means to this patient.
Thanks, Nerida. I was asking you and saying that you have seen lots of physios in the past, and just was interested in a bit of feedback on, I've now seen you 3 or 4 times, is that correct?
Yes.
Could you just tell me what you notice is the difference in my approach compared to other health professionals you've seen?
Well, what I see that has been so different is your holistic approach. And when I've seen a physio or an OT previously, it's been all about getting on the exercise bike, doing the exercises, and your approach has been totally different, where you have looked at everything holistically. What are the factors that have led to the falls? What are the factors, my history, where things have really been delved in detail. And also we've talked a lot about mindfulness, and that certainly has had a big impact on my thinking about the way that I'm moving, the way that I'm walking. So that's been a big difference. Previously, when I've had physio, I've been assessed for falls and risk factors, and then when I've been in rehab facilities, for example, once that risk has been assessed, then pretty much I've been in a gym situation for an hour, maybe 2 hours a day, and on bikes and stretching legs above heads and all that sort of stuff. And that certainly given me a lot more confidence, but I have found that your level of maturity and experience certainly, and looking at it from a holistic, total perspective has made a very big difference.
Okay, well, thanks very much for that.
So that's not about Caroline as a practitioner, that's about the way that she's approaching patients, and she's noticed that difference over time in the way that her patients are responding. In fact, she went away recently to do some training for us, and when she came back, one of her colleagues had taken on a patient that she said, he seemed so resistant. I didn't think he was going to do anything. But what she does is takes the opportunity when she's doing passive treatment to engage people in talking about the active treatment and asking them what they think they'd get out of it if they were to make a change. And what do they think the consequences might be if they don't, and how that would really impact on their daily life over time and the things that are important to them. And she sent away this particular man, and her colleagues said, wow, your patients are so motivated, I can't believe it. And she said, who are you talking about? And that was this particular man. And Caroline just said, oh my goodness, I just did not realise. So a lot of the time we don't realise the impact that we're having until we actually see what happens further down the track. So that's all I have to say. So we can get to your coffee. I know that coffee is very important. Never stand between a person and their caffeine at morning tea. Thank you very much.
I'd just like to invite both speakers up. I think we have 1 minute for one question. If
1 minute for one question.
Yes.
Who's got a question? I saw a hand right up over that side. Bear with me, Professor Allison. I've got to get to the other end. Keep your hand up so I can see you. There you are. I know. It's going to be 20 by the time I finish this.
That's time.
Yeah, right up the back. Couldn't be any higher.
Thank you. Mine's actually a comment rather than a question. Sorry. My name's Jo Connaughton. I currently work at the University of Notre Dame in Fremantle. But prior to that, I worked in acute psychiatry. And I'd just like to say thank you to the APA for these wonderful presentations this morning. You've brought forward everything that everybody who works in psychiatry has been trying to get out there for years. And thank you very much. And I'm glad so many people are here to hear it.
Thank you, Joanne. So, Professor, does that qualify as a question or a comment? Do we go for one more? There's a question there. Hi, hello, good morning, hello, good morning, hello, good morning, hello, good morning, hello.
Hi, Venerina from the Occupational Health Physiotherapy Group. Thank you for the speakers this morning. I've heard a few regulators and insurers talking lately about hands-off treatment, and I find it quite disturbing that they equate hands-off treatment with an active intervention. What are your thoughts about that?
What are your thoughts about that was the last comment?
I mean, I personally become very frustrated around the idea that the cognitive and the behavioural is not linked to the things that we do using our hands. And, you know, as therapists, your ability to touch people is a unique ability that we have as practitioners, incredibly powerful. And it can be used so powerfully to motivate people, to give them confidence to move, to gain the ability to function, to guide them in their function. And so this idea that you don't touch your patients is ridiculous in my mind. That is cognitive. Mindfulness and movement is the ability to be guided in terms of how you move. So you can't disconnect the body from the brain. in my view. And that's why we see cognitive behavioural approaches to management as a body-mind connected approach, not a talk to your patient and send them off doing something. And that's where I think we have such a unique capacity as a profession to be doing something that psychologists don't have the mandate to do.
Jeanette, did you want to make any comments? No? All good?
All good? Yeah. Great.
Professor?
Thank you. So I'm really very excited about where this is going and how we can integrate both active and passive interventions, and not only in the area of musculoskeletal sports, etc., but really across the whole profession and across our colleagues in other professions. And I think this is a way forward. So I'd really like to appreciate the support of the committee to actually allow us to run this plenary session. I also support or thank you for Peter and Janet to actually give these excellent presentations. So thank you very much.